from the American Academy of Pediatrics.
Medical errors happen, and sometimes they lead to adverse events.
The AAP has new guidance on how to prevent these errors and how to talk to patients about them.
I would emphasize that it's extremely important for leadership to take a strong role on encouraging and modeling transparency and honesty when reporting adverse events.
Plus, a new study shows promising trends when it comes to adolescents and their risky behavior.
Although we should be pleased that these types of risk behaviors that can have serious consequences are declining, I think there also is some concern over what they might signify.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with a look at how to talk about errors and adverse events.
One of my very favorite teaching sessions I get to precept for our neonatology fellows involves disclosure of medical errors to patients.
Oh my gosh, is this like an hour-long lecture?
No, we actually get actors to play patients, and we use scripted scenarios that might feel very real for many pediatric healthcare providers on medical error, where a patient was given too much of an opioid medication and it required them to be intubated after a routine procedure.
Oh my gosh, wow. I would really have benefited from that kind of practice in my training. We used to be so hesitant about how we communicated errors and worried about what the consequences would be if families were angry or pursued legal action.
Every time I precept these sessions, I learn something new about how to approach families about medical errors, and I get to see how others navigate these often difficult conversations, which is so fascinating and one of the reasons I became a neonatologist. That is why I'm so excited today to be able to talk with Dr. Laura Sigman. She is the first author on a revised policy statement, Disclosure of Adverse Events in Pediatrics.
Dr. Sigman is an assistant professor of pediatrics and a pediatric emergency medicine physician at Johns Hopkins Children's Center in Maryland. She's also the assistant chief of the Udawood Division of Pediatric Quality and Safety for Pediatrics at Johns Hopkins and the executive director for strategic solutions with the Armstrong Institute for Patient Safety and Quality. Dr. Sigman, welcome.
Thank you so much. Very nice to be here. I'm delighted to be able to talk about this new policy statement that's just come out.
And we are delighted to have you on. And before we start talking about medical errors, can you define what those are for us?
Absolutely. So there are two terms that we use, adverse events and medical errors. And then there are preventable adverse events. So adverse events can fall into a very wide range of categories, including, for example, having an allergic reaction to a medication without knowing in the past that someone had an allergy to that medication. So a child has an ear infection and gets amoxicillin, and they've had amoxicillin before and been fine, but this time the parent calls a few days later and says, my kid has a really bad rash. And it turns out there is an amoxicillin allergy. So that would be considered an adverse event, not necessarily preventable. Change that slightly, and let's say we have a child who we know has an allergy to amoxicillin, and they are prescribed penicillin. And guess what? They have an adverse reaction to the penicillin. That would be considered a medical error because it was known that they had an allergy and we could have prevented them from getting the medication in the same class.
How often do adverse events and medical errors happen in pediatrics?
Well, unfortunately, they happen a lot. We don't know exact numbers in terms of nationwide medical errors, including both adult and pediatrics. We have estimates of numbers that have ranged up to 250,000 deaths per year due to medical errors. So it can be quite a high number. A recent study, maybe 5 or 6 years ago, estimated that medical errors are the third leading cause of death in the US, which is quite stunning after heart disease and cancer. Pediatrics, they're also thought to be very common, but our reporting mechanisms and abilities to detect them are not as robust. We have increasing studies coming out of medical errors. Some studies have estimated around 9% of hospitalized pediatric patients suffering from medical errors, but it's not exactly known. And we are coming out with more and more data to illuminate the amount of medical errors in pediatrics.
You kind of already mentioned that there's not this central reporting system for these, but when these events do occur, how is it that we're keeping track of them in pediatrics?
So it will vary significantly depending on the setting where it happens and the jurisdiction where it happens. Some states have mandated adverse event reporting, and sometimes that will vary depending on the type of adverse event, whether it has serious harm or certain things are mandated reporting, such as leaving a surgical sponge in a patient. But there's less of that in pediatrics. Institutions will have more or less robust reporting mechanisms. So many are familiar with systems such as RL Solutions if one is at a large health system. But for people in smaller private practices, perhaps not under a large institutional umbrella, it will really vary depending on that individual practice's policies and culture. And culture is a very important thing, too, that encourages or can discourage reporting.
And are these errors and adverse events evenly spread across the population, or are there some groups of patients who are more at risk for these occurrences?
Great question. There is little data on this, like in general in pediatrics, but we do know that children are more susceptible to medication errors, with an estimate showing 3 times as many medication-related errors in pediatrics as in the adult populations. As you can imagine, that's often due to dosing with weight-based dosing in pediatrics, as well as patients not being able to sort of speak up and ask for themselves. We also have recent studies in the last 5 to 8 years showing increased adverse events in hospitalized Latino patients, patients who have public insurance rather than private insurance, and patients from families with limited English language fluency. So we definitely think that there's more susceptibility in certain populations. Additionally, children with chronic and complex medical conditions, because there's so much going on in their care, they are thought to have higher rates of adverse events or medical errors as well.
And you mentioned culture earlier. What sort of cultural changes or what sort of mechanisms can we put in place that we know will help us decrease these sorts of risks?
So that is extremely important and has been shown time and time again to be a major factor in improving culture around medical errors, transparency, and ultimately the ability to speak up, which encourages prevention of medical errors. So in 1999, the National Academy of Medicine came out with what was referred to as a watershed report called To Err is Human, and that really brought the prevalence of medical errors into the public eye. Prior to that, it had been more of a deny and defend culture with lawyers, of which I am one, so I will put myself in that camp as well, taking a more, not currently in that camp, but lawyers taking a more defensive approach and being afraid to disclose or discuss any adverse events or medical errors with the patients. That has evolved quite significantly in the last 25, 26 years since that report was published. I have done a lot of teaching with pediatric residents who will say, oh yeah, of course I'm going to be honest about it and report it. And that is a testament to the culture around it. Institutions and practices have a big role in that. So any leaders who take a strong position on being transparent and disclosing medical errors would encourage a culture that is much more honest in that. And that is exactly what patients want. There are some initiatives, one called Just Culture, which looks at treating investigations of medical errors in a just and equitable way so that events are investigated, focusing on the systemic issues that contribute to risks of medical errors and not in a punitive way. So many healthcare groups have adopted approaches that focus on systemic factors, what leads to medical errors, rather than targeting individuals as the bad actors in these situations. So that has a huge effect on the general culture surrounding medical errors and how we deal with patients and their families.
Laura, you mentioned that you were/are a lawyer. How did you go from practicing law into practicing medicine?
Yes, so I did not have a very straightforward path into medicine. I practiced law at the Department of Justice, doing healthcare related Medicare, Medicaid, and FDA civil work, and had an undergraduate background in science and started to think, if I want to make a difference in healthcare, it would be really nice to be able to work directly with patients. So after many years of thinking and much distress, I decided to pursue medicine. And it's been quite a journey, and I feel really lucky to be able to join the two together with some roles in risk management in the past, and now through the Armstrong Institute for Patient Safety, working on issues that cross between the clinical medicine and the regulatory environment that governs it, which brings us very nicely to adverse events and some of the legal ramifications and regulatory and incentive structures that affect them.
That is such a great position from which to consider these events and how we can prevent them. I love that. I want to ask a question with some personal interest. I have a couple of leadership positions in my small rural hospital where I work. When you talk about changing the culture to make it easier to report and easier to prevent these sorts of events, can you give some examples, some details of what does that look like on the ground?
So I would emphasize that it's extremely important for leadership to take a strong role on encouraging and modeling transparency and honesty when reporting adverse events, and in implementing a just culture type methodology where it's really looking at systemic factors, and except in the real outlier cases where there's clearly a bad actor, not focusing on an individual error, but the systems that can improve to advance safety in medical care. Also, having individuals be able to report events through often their online systems, and then making sure there's follow-up about them. So leadership of a practice going back to the group and saying, hey, we know that people express concern that a patient was misdiagnosed with a condition, and we want to say that we've looked into this, and this is what we found, and this is what we can do to prevent this in the future. Whether it's someone getting an incorrect dose of a medication that perhaps could have been caught by a pharmacist on the team or through an EMR type notification. So being able to have that conversation and having it be two ways and not just reporting and not hearing back is really important to facilitate that culture.
And you mentioned this is a collective responsibility. We all need to be looking out for these and supporting disclosure to families. But, I've had them happen myself, and I've seen pediatricians go through having to talk about a medical error, and it feels very personal because our job is to take care of kids. And when something happens that could potentially harm them, we really take it to heart. So how do we on an individual level begin to think about discussing these types of errors with families?
Discussing it with families is something that can be very well taught through different educational initiatives or trainings. And there has been an effort by groups like the ACGME and the American Academy of Pediatrics to encourage training on disclosure. And when clinicians have a sense of how best to disclose, they're much more comfortable with that. There can be simulation-based training. There can be huddles beforehand with people who are more experienced in doing this. Reaching out to support people is extremely important, whether it's caseworkers or practice managers or senior clinicians who one trusts. So being able to go to the resources within one's practice to find guidance on how to have those conversations is really important. And it's also extremely important for the clinicians involved who, as you mentioned, are strongly affected by the events that occur and take it personally and feel guilt and shame, and they feel alone, just as the patients do.
So how do we begin to think about discussing these occurrences when they happen with families?
There are resources available to help clinicians, to guide them in terms of how to interact with families around this, what can be said, There are opportunities to participate in programs in many institutions that offer things like communication and resolution programs, which have been well established, and materials about those have been available on the web. There's also efforts to increase training for clinicians involved in medical areas, either through simulation or education of medical students. And groups like the AAP and the ACGME have talked about the importance of educating clinical workers on how to disclose adverse events. I like to go with a very basic framework that I call the ABCDs in disclosure, which involves apology as the A, backup, meaning getting support people involved to help with the disclosure, communication, which means having solid communication and a plan for how to disclose, D being the disclosure itself, and with an S being support, meaning soliciting support for the healthcare workers involved in the adverse events.
So when you're making this disclosure, is it important to make it in the moment at the bedside, or are there other environments where the disclosure needs to be discussed?
So when I teach about this, I like to talk about a lowercase d disclosure and an uppercase d disclosure. And in academic hospital settings, let's say, or even an outpatient setting where someone is covering on an overnight or on a weekend, there's an opportunity there to have an immediate conversation. And being transparent at that time is very important, while also recognizing that there are many factors that contribute to medical errors, and there are usually systems processes for looking into them. So I encourage people who might be in the scene immediately to have a sit-down conversation with the family and patient, if applicable, and say, we are so sorry that this occurred. And we know that, let's say your child got an additional dose of morphine that they shouldn't have, and that caused some respiratory depression that required more support than we expected. And then to state very clearly that we will be looking into this. We will be figuring out why this happened. We can't say exactly what occurred at this time, but we will be investigating and getting back to you and making a very definitive plan for when they will hear back from other people at the hospital, even if it's not the person at the bedside or with the patient at that moment. And then the capital D disclosure is more of a longer, more involved investigation. It might come after a system-wide root cause analysis or a parent cause analysis, or in a practice with a investigation along with the practice manager. And at that point, there may be an offer for a settlement to compensate the family for suffering that they've been through. There may be attorneys involved, there may not be, but that's the more capital D disclosure that involves a longer process and a bigger team that wouldn't be done right away.
And Laura, you just talked about root cause analysis and apparent cause analysis. Can you explain the difference?
So a root cause analysis is a very in-depth investigation of a serious medical error. An apparent cause analysis is a briefer investigation that looks at medical errors that may not have caused as serious outcomes as a root cause analysis would.
And I think it's inevitable, as hard as we're all trying to do this job as well as we can, that clinicians involved in an error must feel crushing guilt and shame. I know that in the immediate aftermath, I found an after-action meeting to be helpful, but this goes on for a long time. And what kind of support can we offer clinicians who are just haunted by one of these events?
Absolutely. It's a really important question. And for me, when I had an adverse event, I remember my chief coming up to me and some colleagues coming up to me and saying, this is the hardest part of our jobs and I've been through it. And that to me was so incredibly helpful. As a new physician at the time, I felt very alone and sense of shame and guilt. And I think that's extremely common for anyone in clinical medicine who experiences an adverse event. And unfortunately, most of us are likely to go through that. So I think offering support to our colleagues and relying on peer support programs, which has become more and more common. There's RISE programs, which stands for Resilience in Stressful Events, that are offered throughout the country. There's some online resources such as Peer RX Med, available to smaller practices. Sorry Works and many other institutions or practices will develop peer support programs where there can be support for clinicians. Certainly, employee assistant programs and counselors when there's severe distress around adverse events is also a good way to support people when these things happen.
And as a lawyer, you mentioned legal ramifications earlier of these types of events. So how do we balance knowing that that's a concern with being transparent and open with the family?
So actually, new literature has shown that being open and honest can actually decrease the risk of adverse events becoming legal cases and can decrease the payments that come out of legal cases. So there was a study done at University of Michigan, probably almost 10 years ago now, but it showed that an early communication and resolution program had surprising to some, perhaps positive effects on legal outcomes. Many states also have legal protections for offering apologies. Sometimes those go to taking ownership for fault, and sometimes they protect only expressions of sympathy. 39 states and DC, as of my last count, do have those types of protections, with the minority, probably only 7 or 8, having protection for statements of fault. But many states do protect the ability of healthcare workers to say things like, I am so sorry that this happened. I can understand your suffering, and to express that empathy, which is really what patients and families want.
Well, this has been a tremendously enlightening discussion, and I certainly hope all of our listeners are going to read this policy statement end to end because there's so much in it. But before they do that, do you have a last takeaway you want to make sure they're thinking of?
I would say my biggest takeaway is communication, and that goes on many different levels. Failures of communication are seen time and time again to be the most important factor leading to medical errors, and robust communication between teams and between clinicians and patients and families also reduces the risk of legal action after adverse events occur. So communication between teams taking care of patients, between different professions within the care environment, nurses, pharmacists, physicians, physician assistants, those can all be critical in preventing adverse events. And in addition, it's been regularly shown that when doctors or clinicians have strong relationships with families and communicate well, support them, and don't leave them feeling abandoned in their medical care, that the patients and families are much less likely to sue afterwards. So there's important legal protections offered there as well.
Dr. Laura Sigmund, thank you so much for taking the time with us today.
My pleasure. Thank you so much for inviting me to speak.
To read the policy statement, disclosure of adverse events in pediatrics, and more, visit our website at aap.org/podcast.
Coming up, we'll look at trends in mental and behavioral health risks in adolescents.
David, I know you've been visiting a lot recently with your young adult children, and I still just cannot imagine what it's like to have kids that age.
You know, it grows on you slowly. That's the good part. But I've said it before. I feel like my kids just get more interesting every day. They keep introducing me to fresh ideas and artists and trends, which I love. But it can also be scary because now that the statute of limitations has expired, they're confessing to some of the things they got away with when they were younger.
I'm not sure I'd want to know that. Did all of your teenagers have some sort of dramatic rebellion?
No, it was all secret. Trends since I graduated residency in 1998 have actually shown that kids are taking progressively fewer risks with their health.
Yes, but at the same time, we keep hearing about a mental health crisis in teens and young adults. So how does that square with less risky behavior?
Good question. This would make for a very interesting story, and it's actually one that has been researched. Today, we have on the podcast Rebecca Levine-Coley, a PhD and lead author of a new study in pediatrics, Trends in Mental and Behavioral Health Risks in Adolescents, 1999 to 2021.
Dr. Levine-Coley is a professor at Boston College Lynch School of Education and Human Development and director of the Center for Child and Family Policy. Rebecca, welcome to the show.
Thank you very much. It's a pleasure to be here.
So, Rebecca, to start, can you just summarize what we already knew about the trends in adolescent health risks and mental health before your study?
Well, there have been numerous studies that have shown increases in mental health problems among youth and young adults, so adolescents and young adults, so symptoms of depression, suicidality, and completed suicides, actually. At the same time, there has been some indication that externalizing problem behaviors, risk behaviors, things like sexual risk behaviors, substance use have been decreasing over time. But we really were not sure how those things fit together. So is it just that adolescents are substituting mental health problems for behavioral problems, or are they going together in unique patterns across adolescents?
So when you have a question like this, where did your team go to look at data?
We went to large federally funded surveys. So the federal government has funded numerous large-scale surveys that survey adolescents across the country. So we get a view of what youth across the entire country in every state are reporting, doing, and feeling. So we looked at the Youth Risk Behavior Survey, which states run every 2 years to survey adolescents in high schools.
And in this study, you measured trends in internalizing behaviors, substance use, sexual risk behavior, and violence. What sorts of activities do these categories reflect?
So we looked at 8 different indicators, 2 in each of those categories. So the mental health category was both symptoms of depression and suicidal ideation or behaviors. The violence included carrying weapons and fighting, interpersonal violence. Substance use included alcohol and marijuana use, so those are the 2 top substances. And finally, sexual risk behaviors included both the number of sexual partners and whether reliable birth control was used.
And when you were looking at all these things, what trends did you start to see?
So we looked at this by asking, are there patterns in the data that show that there are sort of unique groups of adolescents who show similar patterns of behaviors? And what we found was we identified 5 different patterns. So the biggest pattern, and I think one of the key take-home messages, was that the largest group of adolescents, nearly 50%, showed low levels of engagement both in all types of behavioral risks as well as in mental health problems. Not only was this the largest group, but the proportion of adolescents in this group has increased by about 50% in the past 20 years. So in 1999, 40% of adolescents reported low levels of all these types of behaviors. And by 2021, almost 60% of youth reported these patterns.
And were there particular demographic groups for whom the risks were higher than for others, or perhaps lower?
Yes. So the low-risk group was predominantly younger, and Asian youth were also more prevalent in this group. We also identified numerous groups that showed higher levels of risk behavior. So youth that reported high levels of both mental health and behavioral health risks were only 13%, and this was more common in older and male and youth of color. Some youth engaged or reported just high levels of mental health problems. This was actually the smallest group, but it also increased notably over time. And this group was predominantly younger, female, and were also more likely to be Asian or Hispanic. We also identified 2 groups of youth who reported different types of behavior, externalizing behavior problems. So some youth reported high levels of sexual risk behavior, but not really other types of risk behaviors. And some youth reported high levels of substance use and not other types of risk behaviors. The substance use group was more likely to be white and male.
And I know this is outside the scope of the study itself, but as someone researching these issues, What factors do you think are contributing to how these adolescents are answering these survey questions?
That's an excellent question. There's a lot of research attention to this. Some leaders in the field really point to smartphones and social media as a primary driver of increases in mental health problems. I would say the research on that is somewhat questionable. There's certainly not strong causal research. It's really more descriptive and correlational, but mental health problems started to rise at about the same time as smartphones and social media came on the scene. We also know at this time that youth started spending less time directly interacting with their peers, particularly in unsupervised situations. And economic inequality started to rise. Youth started to report greater concerns about things like climate change and political polarization. And I think particularly when we look at the more recent past, COVID had a very substantial effect on the entire world, but perhaps on youth in particular. And all of these patterns of increasing levels of mental health problems, as well as decreasing levels of risk behaviors, became stronger during the COVID pandemic.
So having examined all these data, do you see an overarching takeaway you'd like to share with our listeners?
I think an overarching takeaway is that youth on the whole are doing quite well in that they're engaging in far fewer risk behaviors that can have serious consequences. So teenage pregnancy, violence can lead to injury and even death. Substance use, when you start early and heavily, is more likely to lead to addiction. So lower levels of these risk behaviors are great signs for public health. At the same time, there are concerns about mental health problems. I would note that the latest data that just came out in the past few weeks from 2023 appear to show that this trend of increasing depression and suicidality and anxiety has finally turned. And the data from 22 and 23 show some small declines from the past couple of years. So that is great news. One other thing I would say is that I would argue as a developmental psychologist and also as a parent, that although we should be pleased that these types of risk behaviors that can have serious consequences are declining, I think there also is some concern over what they might signify. So youth tend to engage in substance use and sexual risk behaviors and obviously interpersonal violence when they're with other youth. And I think what these data also show is that adolescents are spending far less time with their peers. And time with peers is how we develop social skills and relationships that are essentially important for our future participation in a democratic society.
Well, I think you've left us with a lot of hope. Dr. Rebecca Levine-Coley, thank you so much for joining us today.
Thank you very much.
To read the study, Trends in Mental Health and Behavioral Health Risks in Adolescents, 1999 to 2021, go to aap.org/podcast. At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Well, I am coming up on a burst of getting to spend time with my adult kids, especially two of our sons. We are headed up to Nashville to bring the youngest home from college for the summer, and I'm so excited to have a road trip with him. And then I turn right around and go to Massachusetts, where I'm going to address the Massachusetts chapter of the American Academy of Pediatrics and sneak in a little bit of time with my older son. And then we go right back in a couple of weeks to hang on to your hat. She is wearing a hat, listeners. He graduates college, which will make 3 graduates out of 5 kids. So we just have got a heck of a lot of travel and a lot of fun coming up.
Wow. See, my kids are still forced to hang out with me because they live in the house. So we just got back from a Disney cruise, David.
Oh my gosh.
And I think that maybe I had the most fun on the Disney cruise because I found out in planning for the cruise and going on it that I am in fact a Disney adult. And you know what? I've just decided to embrace it.
No shame. No shame. Wear those mouse ears proudly, Joanna. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on YouTube, Facebook, and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producers and editors are Ann Johnsos and Claire Keating. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll discuss a new AAP National Center for Relational Health and Trauma-Informed Care.
We'll talk to two of the center's leaders, Drs. Moira Szilagyi and Heather Forkey. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.